routine examination. In suspected retrograde ejaculation, post-ejaculatory urine is made alkaline and centrifuged. The presence of sperm in the urine proves retrograde ejaculation. Fragmentation of sperm suggests infection. Chlamydial and other infections should be investigated. Sperm fertilization potential is tested. Management of male infertility. Education. This involves sexual counseling, coital frequency and timing, coital position, masturbation leading to sperm dilution. Substance abuse. Advice on avoidance of tobacco, moderate in consumption of alcohol, and avoidance of drug abuse. Pentoxyphylline 400 mg TID improves sperm motility. Reduce heat around the scrotum. Avoid hot bath. Wear loose cotton underwear. Avoid strenuous activities, occupation in hot environment, and control obesity. Correct endocrinopathies. Prompt attention to diabetes and thyroid disorders. Surgical correction of varicocele after the diagnosis has been confirmed on ultrasound scanning helps to improve the sperm motility. Though recently, percutaneous embolization of varicocele is attempted, damage to the testicular artery and recurrence of varicocele makes the microsurgery the gold standard and the best option for varicocele. The obstruction in the vas by microsurgical vasovasal or vasoepididymal anastomosis will restore the patency. Ephedrine 60 mg orally 4 times a day for 2 weeks or alpha-adrenergic drug such as phenylephrine is tried in retrograde ejaculation. Vasovasectomy in the reversal of vasectomy operation yields a poor result if the interval of more than 5 years has elapsed since vasectomy because of the formation of sperm antibodies. Antibiotics. Infection indicates the need for appropriate antibiotics to treat epididymoarthritis, prostatitis, and STDs. Doxycycline 100 mg BD for 6 weeks is beneficial for chlamydal infection. Role of oxidating stress on the sperm function throughout pro-oxidants liberated by leukocyte abnormal sperms is now realized. Lycopene 2 mg daily and vitamin E are found to improve sperm count. Antioxidants containing vitamin E 100 mg, vitamin C 500 to 1000 mg, and N-acetylcysteine 200 to 500 mg TID, carnitine 3 mg daily, selenium 225 mg, pentoxyphylline 400 mg TID, lycopene 2 mg daily for 6 months is reported to improve quality of sperms and prevent the DNA. Premature ejaculation. SSRI take 2 weeks to reach the therapeutic level, but depoxetine works within 1 hour. 30 to 60 mg is taken 1 hour before the intercourse. Hormones. Testosterone, pituitary hormones, GnRH have all been tried to improve spermatogenesis with variable results. Hormonal therapies for male infertility. HCG 3000 international units IM thrice weekly for 12 weeks. Alternatively, 5000 international units twice weekly may be given. Lately, 2500 international units has been recommended. Thereafter, 37.5 to 75 mg FSH subcutaneously is added thrice a week. Follow up with testosterone level and semen analysis. It takes 6 to 9 months to produce normal semen counts. Stop FSH but continue with HCG. About 40% pregnancy rate is reported. Testosterone. An oral dose daily 25 to 50 mg improves testicular function. Larger dose of 100 to 150 mg daily suppresses the spermatogenesis. After a 3-month course of treatment, rebound phenomena occurs with improved spermatogenesis. Clomiphene. Daily dose of 25 mg for 25 days following by rest for 5 days is given cyclically for 3 to 6 cycles. It is recommended in hypogonadal infertility but is not effective in hypogonadal hypopituitarism. Instead of clomiphene, letrozole 2.5 mg may be employed. Human menopausal gonadotropin HMG 150 international units thrice a week for 6 months is recommended in pituitary inadequacy, but it may take as long as 1 year to induce the spermatogenesis. GnRH is indicated in hypothalamic failure. GnRH 5 to 20 mcg subcutaneously 2 hourly for 1 to 2 years. Tamoxifen daily dose of 10 mg for 6 months has been found effective. Dexamethasone 0.5 mg or 50 mg prednisolone daily for 10 days in each cycle for 3 to 6 months is recommended in the presence of spermal antibodies. About 25 to 40% pregnancy rate is observed, though avascular necrosis of the head of the femur, osteopenia as a side effect have to be borne in mind. Cyclosporine A daily dose of 5 to 10 mg per kg for 6 months is better than corticosteroids in T cell suppression. If corticosteroids are contraindicated, an anti-inflammatory agent such as naproxen 50 mg twice daily will lower the antibody levels. Sildenafil or Viagra. A dose of 25 to 100 mg 1 hour before sexual intercourse improves erectile function, but recent reports on ischemic heart disease is alarming and should be prescribed with care. Color visual disturbances, headache, rhinitis, dyspepsia have also been reported. It is contraindicated in men on antihypertensives. The drug is effective in 50 to 80% cases, but it is contraindicated in retinitis pigmentosa, diabetic retinopathy, patient on antihypertensive drugs such as nitrates, cardiac disease, previous MI, and stroke. Artificial insemination. With husband semen for 4 cycles has yielded 30% overall success with 10% success per the cycle. The results are better if combined with ovulation induction for multiple ovulation. It is indicated when there is chronic medical disorder, oligospermia, impotency, ejaculatory failure, premature ejaculation, retrograde ejaculation, hypospadias, antispermal antibodies in the cervical mucus, unexplained infertility. It is also possible to freeze the semen if the husband is a frequent traveler and not available at the time of ovulation for IUI. The semen can also be frozen and used later if the husband needs to undergo radiotherapy or chemotherapy. HIV positive male or female. Techniques used for artificial insemination are IUI, intracervical, pericervical and vaginal insemination. The semen is washed, concentrated. Its quality is improved by swim-up technique or by the use of porcelain gradient. The semen with normal sperms with good motility thus obtained is then inseminated into female genital tract. Obviously, artificial insemination is done around ovulation. About half ml of concentrated semen is injected 36 hours after HCG injection when the ovarian follicle reaches 20 ml. Semen washing removes the abnormal sperms, seminal plasma containing antibodies and other debris as well as the prostaglandins. IUI normally done once around ovulation. Some prefer to do twice in each cycle. IUI is repeated up to 3 to 6 cycles. It should be done within 90 minutes of collection of semen for optimal results. Prophylactic progesterone is recommended to the woman in luteal phase. Artificial insemination with donor semen is now legalized in India and should be undertaken only if the infertility centers after appropriate counseling and explanation of implications to both the partners. Indications are azoospermia, immunological factor not correctable, genetic disease in the husband, homozygous Rh positive husband with previous pregnancy losses, chronic ill health and disease. The frozen semen is stored for 6 months to minimize HIV transmission. If the donor remains HIV negative by the end of this period, insemination is thought and used. Management of azoospermia. Obstructive azoospermia requires vasogram to study the site and nature of blockage. Vasovagal anastomosis has been successful in few cases. The advantage of surgery over ICSI is that one-time treatment and cost effective, if successful with permanent effect. Subsequent spontaneous pregnancies are possible. 5% males suffer from azoospermia. Depending upon the cause, especially hormone deficiency, GnRH and pituitary hormones have been used to induce spermatogenesis. Other methods of treatment for male infertility are IVF, gamete intrafallopian transfer gift technique, microassisted fertilization, microsurgical epididymal sperm aspiration, percutaneous epididymal sperm aspiration, testicular biopsy, sperm retrieval, MESA, supersede other methods in modern treatment of male infertility with improved success. IVF. In this, induction of ovulation is done with clomiphene, FSH or LH or GnRH depending upon the woman's response to the drug. The aspiration of mature oocytes is done under ultrasonic guidance. Oocyte is kept under specific culture for few hours to complete oocyte maturation. About 50,000 selected sperms are used for insemination. About 18 hours after insemination, oocytes are observed for the presence of pronuclei, sign of fertilization, and cultured for a further 24 hours. A 2 to 4 cell stage, 2 embryos are transferred, embryo transfer, into the uterine cavity 1 centimeter below the fundus. The woman is allowed to go home 2 to 3 hours following embryo transfer. Indication for IVF are idiopathic or unexplained male and female infertility, immunological factor in the male and female, blocked fallopian tubes or failed tubal surgery, failed intrauterine fallopian insemination, mild endometriosis, abnormal semen findings, donor semen or sperm. The indications for IVF are expected to expand with rapid improvement. Complication. Apart from hyperstimulation syndrome, multiple pregnancy and its complication, IVF can cause ectopic pregnancy in 5% and heterotropic in 0.4 to cases. 3 to 4 cycles of IVF yield 15 to 30% pregnancy rate. The best results are seen in women with blocked tubes, whereas poor results are seen in oligospermia, teratospermia, and asthenospermia. Gift. Gamete intrafallopian transfer. It involves aspiration of the oocytes following ovulation, induction, either laparoscopically or ultrasound guidance transvaginally. Laparoscopic route is preferred as it is anyway required for the sperm and oocyte transfer into the fallopian tube. 2 hours before aspiration, the semen is prepared, washed from seminal plasma, left in the culture media at 37 degrees. The oocytes are mixed with 50,000 sperms and transferred to each ampullary portion of the fallopian tube 4 cm from the premial end. The volume transferred is 10 to 20 microns. Gift technique allows in vivo fertilization in the natural site fallopian tube unlike the IVF, but needs laparoscopy technique, which is invasive. It is not commonly done now. Lately, transfer of oocyte sperms is attempted by transuterine catheterization of the tube, phalloscopically, and laparoscopy is avoided. Indications are unexplained infertility, failed IUI, male infertility, immunological factor in the male and cervix. Donor semen, if required, is rare. Both the fallopian tube should be patent. The results are better with gift than IVF. 45% success versus 15 to 25. But success rate with IVF is improving. Besides, laparoscopy is not required. Abortion rate of 10 to 15%, ectopic pregnancy, multiple pregnancy have been reported with gift. Disadvantages: fertilization cannot be confirmed. Male infertility. First, we do the semen examination. If there are normal findings, then intrauterine insemination 3 to 6 cycles. If the sperm count is greater than 10 million per ml without ovarian stimulation, maybe with clomiphene or letrozole or with HCG. If IUI is failed, then IVF is done if the count is greater than 10 power 6 progressive motile sperms. ICSI if the count is 0.5 into 10 power 6 with progressive sperms. If semen has abnormal findings, then investigations are done. Biopsy, ultrasound, and hormonal FSH, LH, estrogen, progesterone, and testosterone levels are done, and correction is done, and failure.